has a very similar title. So there were too many things in common, and so I had an alternative presentation for safety. Our colleague from Germany has described to you all tools, practically all tools that you do need to have in the Android suite to make your life easier. Well, I'll try more or less to add a few words on this, on talking about the subject that we didn't approach because there were really a lot of information in this presentation. First of all, the Android suite. Well, the Android suite is a discussion that's very important. In many countries, surgeons are using a portable system, and this portable system has a capability or resolution that is in fact inferior and more than the capability of resolution, the capability of heat dissipation, the capability to get rid of the heat that they produce with long monitor time. And this make the system overheat in time and make portable system surely inferior. So whenever you are able to get a fixed system, it will be a great advantage. With large field width and square field or rectangular fields, no more round fields, but in fact, round fields or brilliance intensifier are not available anymore on the market. X-ray protection is very important. Remember that lateral bands in peripheral vascular intervention reduced by 20 times, I repeat 20 times the amount of scattered radiation to the operator. So lateral bands in lead are mandatory for this procedure. Okay. I'll talk about a few more tools that you may use. One of them is contrast. We use non-ionic contrast, but we use also gas, as you know. I've been talking to you years ago about this, and I really use quite a lot gas to do angiogram. So inject inside the artery carbon dioxide, and I think this is non-toxic and does not damage the kidneys and let you see what you need to see. Go on next. In this case, you see a CO2 angiogram. You can see, because it's a negative angiogram, you see at the same time the lumen and the stent. And the capability of seeing things is at least as good as normal contrast when you are dealing with peripheral angiogram. The problem is there's a steep learning curve, so you really need to learn how to do. If people think that they can be self-taught in doing CO2 angiogram, they will fail. So you really need proper training to have good results with this technique. Next one. Next slide. No? He's refusing. No, it's my portable, he has it. Put the arrow or the space. I mean, eventually we'll give up. No? No? Okay, just a second. You know, it's like my dog. You want me to recognize one master. Like dogs. Rottweiler, they want one master. Okay, as you know, CO2 is non-allergenic, it's very soluble, non-toxic, and of course is non-viscous. This means that you will see very easy arteriovenous fistulas. Go on, next one. And so the time when you are better using the CO2 angiography, because it will reduce cost, you will not have pulmonary edema from fluid overload, and no renal damage. And this is very important. And you can see very well the surface of the stent. So in borderline renal failure is very important, because when people have 4 or 5 milligrams per deciliter of creatinine, that is when they are in a situation that is near to going into dialysis, then CO2 will prevent the problem, and it will not make us risk to bring the patient into dialysis because of an angiogram. Allergic reactions are unknown with carbon dioxide, of course. Go on, next one. This is a retrospective study on 600 procedure. Go on. I'll go fast because Go, next one, because here is the subject of tools, not of statistics, really. And in 15 cases, we were absolutely unable to obtain a good angiogram, because you need a patient that is peaceful and still. He has not to move, because if the patient moves, you will not see anything. You really need a good digital subtraction angiogram at high speed, at least 4 to 5 photograms per second. Otherwise, you will see nothing, or you will see false images that you will not be able to interpret it properly. CO2 angiogram cannot be done without proper subtraction. Complete success was seen in 482 procedures. In 157 procedures, you needed to integrate CO2 with a tiny amount of iodine contrast, but this still let you use less than 20 milliliters of contrast for the full procedure. Go on next one. Complication. The most usual complication is diarrhea and abdominal discomfort. This is the most common problem. And the more CO2 you use, the more diarrhea you will see. So you have to take it easy with that. And you have to be careful when you are studying aneurysm, because CO2 may form a bubble inside the aneurysm that does not get reabsorbed. So you need to roll the patient in the bed at the end of the procedure to make sure the CO2 is properly mixed and moved out of the bubble area of the aneurysm. Also, the renal arteries occasionally may not be visualized properly, because some of them may lay very posteriorly. The CO2 is a gas, it goes upward, and so it may not visualize a posteriorly located renal artery. We are studying the possibility of using argon for CO2 instead of CO2 in certain cases, but this is really at the initial development study. Go on. Remember that hybrid procedures are becoming more and more common. The question is that we have a lot of tools, and the question is that if we combine interventional tools with surgical tools, we can achieve the most. And we may have a point to where we may attach a bypass after we put a stent on a proximal artery, or vice versa. We can have a distal point where to attach a bypass if we open with angioplasty the distal artery through the bypass. Suction devices are very important. I see they're using in Russia too. They are even more expensive in this country. So these are the systems that are used to heal wounds, and they radically change the results in limb salvage. Remember that when we look at statistics in interventional procedure and we talk about limb salvage, this is something that is just in the air. It's very difficult to know what saved a limb. Is it the angioplasty? Is it just the fact that you are really taking care of the patient? Is the patient is alarmed? Is that your angioplasty is giving flow? Or is proper care of the wound and of the bacteria? It's not clear. So all the data that talk about limb salvage have to be looked at with careful care, absolutely careful care. The only thing that may assist us is patency. If real patency is present, then we have a success. If we obtain limb salvage, we need to understand why we did. Go on, next one. Incidentally, many times in the angio suite, you do need to give analgesia. I'm sure that many of you abandoned doing the procedure because they couldn't keep the patient still because of pain in the leg. Spinal analgesia is a good solution, and is given by preparing the 4 milliliter solution of fentanyl, glucose, and non-hyperbaric marcaine. The difference with spinal anesthesia is that this does not give sympathetic block. So you have no changes in heart rate, no changes in blood pressure. And it's much, much safer for the type of patient we are approaching. Also, you do it through a 27 needle, very tiny needle impression while taking aspirin or Plavix. Go on, next one. You must have a portable Doppler available, because sometimes you go retrograde through the foot and you do need to find the dorsalis pedis to puncture, and the Doppler will help you out. Go on. Let us finish this. Go on. Type of guide we use, I think my colleague talked a lot about similar things, so we will go on. Next. Access, there's a lot of discussion on access. Cardiologists are steering toward transradial access. My impression is that the nearer you are to the lesion in peripheral surgery, in peripheral angioplasty, the highest is the chance of success. Because we are dealing with completely occluded lesion most of the time when we are dealing with limb salvage. If we cannot exert enough pressure, we will never be able to cross this lesion. So the nearer and the more direct is your access, the better will be. Of course, there are special introductions available for radial arteries, but they are still very complex things to use for opening completely occluded distal arteries. Next one. French side, we are dealing more and more with the smaller French side, particularly with CO2, and with the newer stents available. Invatec made stents that are 3F self-expandable, and Abbott and Biotronic made 4F long stents, so the 4F is a good standard. Go on, next one. Next. Stent versus not stent is an open debate, but I think there are a few Cochrane reviews of the fact that seems that stented lesions do better than non-stented lesions. Go on. Stent have to be put properly though. Otherwise you introduce bias that is inappropriate. So if you put stent, you need to do a control on flexion angiography, that is with the knee bend, and you will see that stent that look perfect will kink and will not let the blood pass. Go on. So revising them will solve the problem. And this let us put long stents behind the knee with no problem. Go on, next. Next. Results change if you do flexion angiography with much better results, the green line below, than when you put the same stent without flexion angiography with poor results when you insert the stent onto the peroneal, tibialis posterior, and popliteal. In those cases, stents behind the knee will fail if you don't do flexion angiography to check the knee. Go on. So again, success probability greatly increased with flexion angiography. Go on. Go on. We are not interested in results like this. And long stent behind the knee will do fairly well in non-diabetic patients, much worse in diabetic patients. We really don't have proper solution for diabetic patients out of bypass. We are trying anything, drug-eluting stents, subintimal, but the distal bypass to the foot remains the best procedure when it can be performed. No? I'm running out of time, I think, so I think I should stop, because again I changed the lecture not to interfere. Okay, I think I stop here, I don't want to bother you too much, but a last conclusion. We have developed as much as we could this technique. We are in the same situation that our colleagues were before Jan Fleming found penicillin. We have found no real solution to the disease. We need to find a more radical and effective solution, different from what we are doing now. We have reached the maximum of the perfection of this system. This system, in my opinion, is not adequate enough to approach this problem. Thank you.